Good afternoon and welcome to the Independent Scientific Advocacy Group's public meeting. Today we are going to address the topic of the COVID-19 response and vulnerable groups in society. And so this is a very big topic and we're really delighted that we have some wonderful guests for you today. It's something that I think we've seen in Ireland and throughout the world, that this pandemic hasn't affected everybody equally. And there are some groups who are particularly vulnerable, and it's very important that we can reach out and address that and make sure that our pandemic response is really thorough and it's working for everybody. So I think it's a very important topic. Just to remind everybody, the Independent Scientific Advocacy Group is a group of scientists, doctors, and others who have come together to advocate for an evidence-based approach to the pandemic response. So as usual, we're going to start the day with a situation update, the stats and the cases and all of this information. And today we're getting that from Dr. James Merrick, who is a mathematical scientist with Gal Research. Thank you, James.
Thank you, Aoife. Agus, do you agree with Carja? The little synopsis before we go into the data is and the charts is that things are pretty stable in Northern Ireland and in the Republic. The real story is kind of continuing rise in cases among young people and children. So if we could go into the slides, please, Ben. That's great. So this chart. So great. So yeah. So if we could just go to the first chart, please, Ben. I will start with Northern Ireland this week, and I'm sorry, yeah, this is the last chart. If we, so if we go to the first chart, please, Ben, and yeah, that's great. So yeah, the next chart then is Northern Ireland, and things are stable there. Is the short of the story. In the blue line is under 19 schools returned, and testing criterion changed to testing asymptomatic close contacts. Cases reported did rise in children, but this has leveled off. And by and large, we're on a linear scale. This is the daily average cases per 100,000, and the black line is the kind of population-wide daily average cases, and we can see it's kind of a stable number, relatively low level, and the vaccination rollout and continues. So stable is the summary for Northern Ireland, and we'll be keeping an eye on things. So if we go to the next chart, we'll go to the Republic, and we'll split it again. Between the blue line is healthcare workers, and the yellow-orange line are non-healthcare workers, the majority of the population. And healthcare workers are largely vaccinated. We can see low case numbers still continuing to decline. But again, the point we've made before, it still takes time to get to the bottom of the chart to zero. So the majority of the population, the yellow-orange line, cases are rising in the population. If we'll just break it out by age over the next few slides. And if we go to the next slide, please, Ben. So just as we'll see, as we flick through the next three slides, we're going to see the lines gradually get higher and higher on the chart. So this is the older age groups, over 65s. Green line is over 85 plus. We can see the cases are really down very low, which is great, and going that way with these other age groups too. If we go to the next chart, please, Ben, there's a bifurcation in the next age groups between 55 and older. That's the red line here along the bottom, and we can see it's pointing downward and has broken away from the other groups, and we see this increase starting to happen in the younger kind of middle age groups. And if we go to the next slide, please, Ben, that's the real story in terms of the population-wide cases. Young people. So there's a lot happening. We saw schools reopen, and as we kind of worried about, we felt as discussed in ISAG white paper and ISAG schools webinar, more could be done. Mitigation measures, particularly to prevent airborne transmission, could do more screening testing. More could be done, and and this is what we're worried about: cases rising. Clearly, there's more in the schools going on as well. The 15-24 age group are, there's some of those are school going, some of those are not. But this is the story, and great news, I suppose. The vaccination rollout around Europe and Ireland is really picking up, but between now and the population's vaccinated, what's going to happen? How many people are going to get infected, and what are the long-term impacts? And a small, people say that a small, only a fraction of young people get sick from COVID, but a fraction of a very large number is still a large number. So this is the sort of discussion. This is the story, I think, young people and what we're going to do about it, or not do about it, which is concerning perhaps. So next slide, please, Ben. Oh yes, so there's also a regional story. Donegal was in the news a lot the last few days. Donegal is broken out, selected regions broken out in the Republic. The Donegal is the orange-yellow line here at the top, but Donegal is clearly not the only story. Kildare is the blue line, and it's actually rising quite sharply. And there's some high-profile outbreaks in schools and workplaces in Kildare the last couple of weeks. Cork and Kerry we used to show together on these regional charts in previous weeks. They're at the bottom there, but there's been a split. Kerry is very low, zero cases. We can see a lot of days, but Cork has on a sharp upward rise, and I'll lump in Tipperary into this story. Tipperary is a green line, and that's been quite low for a lot of the last 6 months. Tipperary, and there's a story. Tipperary, one case, I think the story of a friend in Nina was that one case became 190 in what felt like a blink of an eye to the locals there. And so it was a mixture of one case came into a social gathering, went into schools, went into households, and it really ties in with a small import. And this is a lesson here for the island as a whole. A small number of importations can really drive high numbers a few weeks later, and we've heard their stories this week about the contact tracing system and travel, which I believe we're going to touch upon later in the webinar, which is an important part. And some of these regional stories I think play into that. A final slide then is our just setting up today's webinar. If we look at the bar chart first, the bar chart are the cumulative number of outbreaks since late December to up to the end of April, in different settings, and educational settings, and that includes down are the largest number of outbreaks, and then followed by vulnerable groups, and vulnerable groups are defined in the HPSE data as traveling community, homeless people, direct provision residents. And so they're high on this list, and you can see the other settings there. Ones you'd expect: workplaces, hospitals, residential institutions. And just at the table on the right then, in terms of cumulative number of cases after nursing homes since December, the highest cumulative number of cases across these outbreaks was in the traveling community, and one particular outbreak leading to 130 cases. So that's just to set up. And an important point, I should say, is members of these vulnerable populations, they're not just within those populations, they go to these workplaces, they go to these schools, they go to these hospitals, and so it's part of a broader story. And so let's just set up that there's just high degree of virus incidence, and follows into hospitalizations and deaths in these communities. So that's the situation update. Thank you.
Thank you, James. That's really very useful. There's a lot in that. And I think your last point there about the high incidence among vulnerable groups really is the motivation for our main theme today. I think sometimes when you listen to the government, it seems that they presume everybody has a particular home setup, that they've got space for isolating at home, that they've got gardens to exercise in and get a bit of fresh air in and things like this. And of course, this isn't the situation for everybody. I think it's also very interesting what you showed there with the regional differences. Like you mentioned, Donegal has been in the news a lot in the last week, I think somewhat unfairly. And we shouldn't be taking our eye off other parts of the country. And I think if I was in Cork, I would want to make sure that I was protecting the very good situation down there. So it's still a good situation. It's not bad in Cork, but like you mentioned, it's going the wrong direction again. And maybe it just tells us there's no room for complacency. And I think it's also very interesting what you show with the difference between the healthcare workers and the non-healthcare workers, because that clearly shows the impact of vaccination. And that's really, really great news that the healthcare workers, we can see their cases are going down, but we also see it does take some time. And I think people need to recognize that as well, because there is somewhat a feeling in general, and I think it's a certain impatience, and I understand the impatience, that as soon as a small number of people in the vulnerable group are vaccinated, that we can really take the foot off the brake. And that's just a risky strategy, and we don't want any more unnecessary and avoidable disease and suffering in this country. So to be just to not take our eye off the ball at the last moment. Thank you, James. It's just really, really very useful. So our first speaker today is kind of talking, it's going to be touching on this topic. I think it's going to be Claire Kelly. Dr. Claire Kelly is an Associate Professor of Psychology in Trinity College Dublin, and she's going to talk about optimism bias and the psychology of reopening. Thank you very much, Claire. It's great to have your contribution today.
Thanks, Aoife. Yeah, I just wanted to take a few minutes to consider some psychological perspectives, I suppose, on the current situation. So, like many others, in addition to the weekly cases that we've all been keeping our eye on, I've also been watching the findings of the Amara weekly public opinion survey that's conducted for the Department of Health. And the survey from this week tells us that the news of reopening has been very positively received. So there was a trend of increasing positive emotions like happiness and hope, and decreasing negative emotions like frustration and stress that emerged over April, that's really been consolidated now. So almost 2/3 of people now feel that the worst of the pandemic is behind us, and about the same proportion feel that the government's reaction to the pandemic is appropriate and that there shouldn't be further restrictions. Slightly less than half feel that Ireland is trying to return to normal at about the right pace, while less than 1/3 feel that things are happening too quickly. So clearly, people are very understandably really happy about the prospect of easing restrictions after what has really been a very long and very tough level 5 lockdown for everyone. But, unfortunately, and the situation report has just, emphasized this point that, the government really didn't put that lockdown to very good use, and it was relatively ineffective in that it didn't succeed in bringing case numbers down to where they need to be in order for us to safely reopen our society. So we know that cases are at, we have more cases now than when we were at the beginning of our disastrous reopening in December. And we're also on an upward trajectory, particularly in those younger age cohorts. So, of course, one very obvious difference between now and December is that we have largely vaccinated our most vulnerable and our frontline healthcare workers, so people who are either at greater risk of exposure or at risk of greater risk of hospitalization and death. But as we talked about in last week's public meeting, it's a mistake to focus on hospitalization and death alone as the outcomes of COVID-19 infection, because there's really mounting evidence of very significant long-term disability associated with long COVID. So I just wanted to take a few minutes to talk about some of the quirks of human cognition, of human thinking, that can help us to understand this current situation, this disconnect between the data or the reality that's in front of us and our government's response to it and people's response more generally. So there's, of course, many different psychological influences, but I wanted to draw attention to a few that I think are particularly relevant at the moment. So the first of those is optimism bias. So that's our tendency to believe that we are less likely to experience negative events than other people, and more likely to experience positive events. So time and again, studies find that people underestimate their chances of being in a car crash or getting divorced or getting COVID, while we overestimate our chances of living a long life, or overestimate the talents of our children, or that something that a magic bullet like vaccines alone will solve all of our current problems. And very strongly related to this is our tendency to only consider favorable information or evidence over unfavorable information. So, for example, focusing on reduced hospitalizations and deaths, but ignoring information about long COVID. And then there's a related belief that lightning never strikes twice. So what happened in December couldn't possibly happen again. So optimism bias is really important for human resilience. There's a lot of evidence to suggest that it's actually adaptive for the most part, but putting on our rose-tinted glasses and always looking on the bright side can have negative consequences, particularly when, or because humans are also pretty bad intuitive actuaries. So we're not very good at thinking about risks and probabilities. And one of the challenges with COVID-19 is not only that we're dealing with risk or uncertainty or probability, but we're dealing with ambiguity, which is that there is risk, but we can't quantify it. We don't know exactly what it is. So while we currently have a reasonable sense of the risk of, say, hospitalization and death for people of different ages, at least for the virus variants that we have become used to or we have experience of to date, we don't have a good sense of the risk of long-term outcomes like long COVID. We don't have a good sense of the risks associated with the new variants, the ones that have either recently emerged or those that will evolve in the future, how much more transmissible or more deadly they may be, the extent to which they'll show immune or vaccine escape. All of the risks and probabilities in these situations are ambiguous, and studies again have shown that optimism bias is actually exaggerated under conditions of ambiguity, so leading to a stronger belief that things will turn out okay, and leading people to pay better, more attention to the data that supports their belief than data that doesn't. So this understanding of risk and probability plays into another cognitive quirk that's known as temporal discounting, which is our tendency to overvalue things that we can have right now and to undervalue or discount things that we can have in the future. And the more distant or uncertain the future gain, the more we tend to discount it. And this tendency is also exaggerated by the experience of scarcity. So this happens, for example, in poverty, but we can, extrapolate to conditions where resources or access to those resources is restricted, like lockdown. So an understanding of this phenomenon can help us to, appreciate the appetite for reopening, for a return to normal now, to hell with the future cost. And so we're very likely to see a very enthusiastic uptake of any and all freedoms under the loosened restrictions, and a bit more besides, despite the fact that this might not have a good long-term outcome in terms of infection rates. So there's one last thing that I wanted to touch on, and this is a phenomenon known as psychological distance. So this is something that is important for helping us, I think, to understand our tendency to look away from the horror that's been taking place in Brazil and India. So psychological distance is essentially what it sounds like. It's a cognitive separation between the self and other people, other places, other experiences or events. And it's inversely related to empathy and action. So this is a problem we come across in the context of the climate crisis, where the worst impacts of that crisis are currently felt by people who are far away from here and who are culturally or ethnically different from us. And this leads to inaction. And early on in the pandemic, I think there was a real sense of borderless camaraderie. So, that we were a global community coming together to fight against this new threat. But over the course of the past year, the enemies of solidarity, of community and cooperation, economic and commercial interests have really dissolved that cooperative spirit, to the point that humanity is really now on the verge of committing a catastrophic moral failure, as Mike Ryan of WHO has said, one in which we will see young people in high-income countries vaccinated over frontline workers and the vulnerable in low-income countries. So each of us needs to work very deliberately and rationally to overcome that psychological distance, to bridge that empathy gap, and to realize that not only is our inaction on what's happening elsewhere in the world wrong in itself, but it increases the probability that we could see more transmissible, more deadly variants emerge that could end up on our shores. And that what is happening in India and Brazil could happen here. To repeat some other wise words, this pandemic is not over for anyone until it's over for everyone. So I'll finish with that, because I know that Anthony Staines and Dr. Fitzgerald are going to touch on both of these things and talk about health inequalities and social exclusion, vulnerable groups, as well as the issue of variants being imported from overseas.
Thank you, Claire. That's really interesting. Because I have the tendency to think of optimism as a good thing. And I'm sure most of us do. And to also realize that sometimes optimism might blind us to reality. And the blind optimism, I suppose that phrase exists for a reason. And it is true that in this pandemic, the short-term goals are inconsistent. Short-term gains are inconsistent with long-term getting out of this and staying out, and unfortunately we've demonstrated that a few times now. But that's really interesting, Claire. I'm sure there'll be some questions about that as well. But now I want to move on to our guest today, who is Dr. Margaret Fitzgerald, who is a public health lead for social inclusion and vulnerable groups working with the HSE. And today she's going to talk to us about her work and about the work that public health doctors are capable of and the kind of things they can do. And I think this is very important, because one thing we have seen over and over again is that there is a certain lack of understanding about what the role of a public health doctor is, and there's certain confusion about what they can do. And we have seen very clearly during this pandemic that this has not been affecting everybody equally. And, that public health doctors have already been thinking about how to tackle this problem and how to have a better outcome for everybody, I think is really important and perhaps is not common knowledge. So Margaret, it's really wonderful that you were able to give us some time this afternoon, and I'm really delighted to hear your contribution. Thank you very much.
Thank you. Shall I start?
Go ahead, yes.
Okay, so thank you all very much for inviting me to talk to you today. And I know some of you already, and some others I have seen you on dispatches. So I feel very privileged to be asked to speak to independent scientists on this very important topic. And just your introduction about public health and the interface with socially vulnerable groups. I joined the HSE National Social Inclusion in 2017, having been a director of public health in Dublin for several years before that. And it's like, welcome to my world. The Ireland that we live in today is so different to 2010, 1990. And even looking at reeling in the years, you can see visually how Ireland has changed. And what our experience working with socially vulnerable groups in Ireland is that you bring together, it's the art and the science of public health practice, because so much of it is about nuance and about culture as much as it is about epidemiology and statistics. So anyway, who are the vulnerable groups? 17% of our population weren't born here. So that's for starters. We look at the top key groups that we're concerned with would include homeless. There are 10,000 already registered in the Dublin region, but we have homeless in most metropolitan parts of the country, Cork, Limerick and Galway. And other areas around the eastern seaboard would house homeless groups, including, the Midlands. Some of them are very medically vulnerable, such as those with comorbid conditions such as addiction and opiate addiction and alcoholism. Others have mental health, and some are family groups. In addition to homeless, we have about 30 to 35,000 travellers based on the 2016 census. And travellers are families, large families, and are dispersed all over the country. They have high concentrations in certain parts of the country, Galway, Midlands, Dublin region. Every region really has travellers, and they are a young, mobile population. 45% of the travellers are actually under the age of 25. And the other groups we are concerned with would be people who seek asylum and are living in direct provision. And we would have had a peak of about 4,000 to 5,000 seek asylum in 2019. And about 7,000 live in the direct provision system. And many come from African and Asian communities, so they would fit the BAME definition as seen in the UK. And then we have our Roma. These are about 5,000 and very dispersed, quite hidden, and are EU nationals. So I won't go on through the list. Those affected by opiate addiction and alcohol, I've mentioned, there are 10,000 on methadone in the country. And undocumented migrants, we're not sure if there are thousands of them, and also victim of domestic violence. So if you want to go on to the slide on the next slide there, thanks very much. So we have endemic problems in the country that have come to the fore during COVID. We have chronic problems, homelessness, we have stigma against travellers, we have racism for non-nationals and Roma, and we have people whose life expectancy is considerably shorter. So we inherited these, and then during COVID, we have seen how this has panned out. And the first thing we did was really to engage with the community. Early awareness, early action. And that was involved getting to know people, getting to know you. And for me, that was a journey, and we're still on that journey. Part of that getting to know you was also to link our own social inclusion colleagues in the HSE with public health. For some reason, and over the many structural changes in the HSE, they had been in parallel universes. So that has been a huge part of my response, is having weekly meetings with public health colleagues and then bringing on board social inclusion. In the HSE, social inclusion is a very small division. It's just about 100 plus people working across 9 CHOs. Only about 10 people max at the national office. So, so early action and then targeted response. And that included, the way we operated, which was, we took our steer really from my own experience working with Ebola in Liberia in 2014, where, and other outbreaks and other major epidemics I've been involved in, and humanitarian crisis throughout the world. And at one stage I worked with Mike Ryan in WHO. So like his mantra was, take the fight to the virus. And literally that's what we did. We, with a very tiny team nationally, it was Joe Barry, Gabriel Fitzpatrick, myself, and Jane Ann McKenna that came from MSF. We took this approach where we would just go out there and fight, either meet the outbreak in the location, in the hotels, or in whatever setting, and test aggressively and try and get outbreak control teams set up. And we did this by bringing on board as much as we could each local area. And that took a lot of work and a lot of effort and a lot of fighting and a lot of telephone calls. So so a lot of what we did initially was face-to-face social media. We have to remember, our groups don't necessarily watch RTE. They don't read the Irish Times. They're not mainstream. So we have to do things differently. And we try to do things differently. But you do things differently, but no one group is the same. It's not one size fits all. So apart from the early awareness and early action, we also look for bespoke solutions. And each wave has given us different challenges. So, and I have to say that the experience for the vulnerable groups has been hard and harder than the general population. And in the first wave, the greatest impact was in settings such as direct provision, travellers and Roma. And we could see a lot of high-profile stigmatizing events. And in the second and third wave, we've definitely had ongoing issues with control and morbidity and deaths and increasing stigma. And that's probably part of the reason why you don't get the same exposure or the same media exposure that that you might see for other groups. So do you want to share the next slide there? Thank you. So this is some of the ways we might engage with, say, the traveller community. Stop this spread, wear a mask, simplify the language. And we've done this for different groups. For migrants, for example, we literally translated into multiple languages, and we got extra funding from social inclusion to work with Translate Ireland. With travellers, we worked very closely with Pavi Point and did our own webinars, our own videos, got the travellers to do it, WhatsApp messages, saying words like, people of Tuam lay low, because you know, that's the sort of language in that particular area. So it was very bespoke, very local. If you want to show up the next slide there. So there you can see, you know, the travellers themselves. So we used our own peer workers, traveller health units, primary healthcare workers, and as far as possible, that's how we operated, downstream very much, and face-to-face imaginative solutions. So if you want to go on from there. In the homeless, so if we look at, say, some of the homeless, what we did was, in Dublin in particular, with so many homeless, we had already very strong engagement with the clinicians. So Austin O'Carroll we asked him to lead a clinical Dublin homeless COVID team with a social inclusion colleagues. We then protected the most medically vulnerable homeless by putting them into cocooning and shielding units. And in the first wave, we had greatly protected the impact of COVID on homeless, because we really cocooned them and minded them. And in fact, ironically, we had very good results in the homeless sector. We put in place measures such as putting people on maintenance benzodiazepine, putting people on fast-tracking people onto methadone, organising special accommodation for rough sleepers, all the sort of things possibly we could be doing before COVID, but they really worked very well. Having said that, we were hit quite badly on the homeless side in the third wave. If you want to go on to the next slide. And so look at this is the snapshot of where we are today. And if you want to go on to the next slide, you can see I can see the Donegal, and I have to smile at, you know, how we demonize some counties and some regions. You know, so many of these counties would have had disproportionate numbers as well in the vulnerable groups. But because of the way public health teams manage, we try to take the focus off the media, because it would backfire, and it has backfired. Where the media get involved in the outbreak, it's not helpful necessarily. So if you want to go on from there, I just want to show you so one of the great initiatives we started during COVID was setting up our own outbreak response type team. So we use words like rapid response, bespoke solutions, fast track, cluster. So we, social inclusion, we had a very positive experience with Safety Net, and just coming in today I could hear Fiona O'Reilly on the Claire Byrne Live show talking about Safety Net approach to vaccination. So Safety Net is an NGO, a bit like MSF, set up with Austin O'Carroll and currently led by Fiona O'Reilly, who I actually worked with in Sudan, and God knows I won't say how long ago because that is going to be too revealing. But let's say we, Live Aid would have been one of our partners, but their approach has been very much to work with, go to this outbreak and have a response that's tailored to the needs of the community, whether they're travellers or Roma, work with public health, work under the governance of the medical officer of health, and do the contact tracing and the testing in with us. So they're our partners. And through that, we've led out on many outbreaks. If you want to go to the next slide. And that's the sort of measures: identify and isolate, test, trace, and test again. So many of our settings would have had multiple serial tests as a result of outbreaks and clusters. If you go on to the next slide. Now I'm going to look at some of the caseloads. You mentioned travellers. It's actually been enormous. We're running at thousands. We have over 5,000 traveller cases to date. We have multiple outbreaks that in some cases, we cannot count. That slide shows you the proportion of all cases by week in the community. And you can see there that at some point, and the travellers, which account for 0.7% of the Irish population, the caseload could be as high as 5%. And in some places, in some counties, in some localities, we talked about 20, 40, and even in some small areas, 80% of the caseload could be accounted. So it's been a huge burden, and we can see the trend is dropping a little bit, but we are still struggling to control traveller outbreaks. Travellers and the cases tend to be very young, often male and mobile. And this particular pattern we would see also in some of the other groups. If you go on to the next slide. Homeless, as I said, after a fairly, a moderately rocky but not very heavy start, and in the second wave, with all our control measures, we didn't have many outbreaks or cases. In the third wave, we are still struggling to contain outbreaks in homeless settings, and these outbreaks are not just in single settings where you have large groups of males and or females circulating and mixing at the doorways and sharing maybe alcohol or even crack pipes or whatever. They're also in family hubs, and several thousand families are in homeless hubs, whether they're in old hotels or other type of residential settings. So if you want to go on to the next slide. And that just shows the homeless outcomes. We had relatively few deaths in the homeless sector. We had a moderate amount in the traveller sector, if you go on to the next slide. But in the third wave, we've had much higher rates of mortality and morbidity, particularly in single homeless, in travellers, and especially in Roma, to such an extent that we have lobbied significantly and actively with the government to consider that all travellers and all Romas adults are actually medically vulnerable. So I don't want to take up too much of your time, and I didn't want to give you too many facts and figures, but if people are interested, we can deliver some of those. And I suppose the one figure I was going to share was in the direct provision also, we would have had 5% positivity in the first and second wave. So we'd have 5% of all people in direct provision would have had COVID before the third wave, which is very high considering their relatively small number. And we've had good control in the third wave, but it's a struggle because many people in direct provision also work, and they work in crowded environments. So it's not just confined to direct provision. We have worked with immigrants, we've worked with people from Brazil living in very crowded private housing in Dublin. So, and now in the current situation, we're putting our attention onto the way the UK variant has really caused this rapid spread in the third wave, how it has also affected the staff. A lot of staff in these congregated settings are also have been affected by COVID. The variants of concern have also been an issue, and I'm currently working on the quarantine rollout for people who seek asylum. And we have a special bespoke facility set up for those who seek asylum or those who don't fit the mainstream, which is a sort of a humanitarian type of quarantine, because we cannot force people to stay in asylum. So COVID has highlighted the inequalities in our society and how hard it is to reach our vulnerable groups. And as I said, it's not easy to contact trace a member of the travelling community or somebody who lives in a congregated setting. Can't do that by text or remote call. And then how can people who don't have a home or who are not officially in the country, how can they isolate? And you mentioned that already, people who don't have gardens and that. Sometimes outbreaks can generate excessive media interest and social stigma. And then we have a challenge. The young get COVID, but the illness burden is on the older. So how do you try to get people to row in behind you the way the mainstream population do? And some of the ways we've done that has been quite interesting, and we're learning from that because there's an awful lot of things that are good that we're doing. So really what's different about what we have tried to bring forward from the HSE perspective is bespoke solutions, initially very much going on site, engaging, getting to know your people, having specialists in public health medicine who are interested in all public health departments, peer-led contact tracing, peer-led support, especially for the vaccination, a lot of top-down HSE engagement as well as bottom-up. One of the biggest success we've had is working with other government departments like the local authorities, Department of Justice and now Children for direct provision, Housing First, Dublin Region Homeless Executive. NGOs have been an enormous support. We are really, social inclusion is so much dependent on Section 39 agencies in this country, and we have really learned to work better together. And the biggest thing now that we're focusing on is the vaccine, and we focused on advocacy, and we've got some successes. And today, NIAC have actually recommended traveller roam and homeless as being a particular risk. And today is the first day of the rollout of the Janssen vaccine in homeless in Dublin. So as I speak, my colleagues are literally lining up in King's Inn Street in Dublin. They are literally going to give the first vaccination. Do you want the next one onto that? The 700 medically vulnerable homelessness people, and then we're going to roll out from there. And what does the approach mean? It's a lot of it is going to support. We need GPs on board. We need mass clinics, but we also need special clinics. And we need buddies, and we need to listen to what people want. And there's an enormous amount of work involved. In fact, there's so much work that it can be a bit overwhelming. And perhaps if I just leave it at that for now, and maybe get optimism supremes. They're just the last slide, perhaps. The next one after this. Okay, so I like the way Mike says, and he said this, and he's been very quiet recently. So be fast, have no regrets, be the first mover. Perfection is the enemy of the good. And I mean, there's a number of those mantras. When I was working with MSF, we used to say we're learning as we're doing, and that's what we are. And it's a world, and it's a partnership, and I cannot take credit for anything other than to be part of this world, and it's a privilege. And part of the thing I've said to people, as we're working with them, we will not forget you. I've said that to different groups because they did feel forgotten.
Thank you, Margaret. I think that's a wonderful note on which to finish. I think, what you're saying there, the amount of work you've done is extraordinary, and it's such important work. And I think, as you highlighted there, one of the very important things is that you have been engaging directly with these communities and having peer-led initiatives. And that is extremely important. In fact, I just would like to say we did try to see if some members of some of these groups could be present today and participate, but unfortunately we weren't able to find anybody who was available. But it is a very important factor. We have loads of interesting questions for you, Margaret, but before we do that, I want to bring in Anthony Staines because I'm aware that he needs to leave shortly. And there's a very interesting piece of news that came out this week, which was in the Irish Examiner. There was a whistleblower report from a contact tracer who was talking about contact tracing international flight arrivals, and how there was one flight in particular that was highlighted in this article where there was a number of people there was somebody who had tested positive, and when they tried to contact trace the rest of the plane, some of them also tested positive, indicating that transmission potentially occurred during travel, whether it was in the plane or in the airport. And some members of that flight were not contactable. So this is a big hole in the contact tracing. And just like to bring Anthony Staines in, if he has any comment on this, and perhaps also what are the measures that we need in our public health system to address this kind of problem?
Okay, and in terms of the flight, I think this shows us a point that really has hurt contact tracing. Like every other country, we're caught in the hop by contact tracing. Unlike most other countries, we're still hopping. We're still using the tools, methods, and approaches we brought in the first days of a crisis. And we have failed to bring in proper methods. We've failed to sort out the barriers in the system. We failed to make the system work well. I spoke with New Zealand colleagues who started out their contact tracing pretty much where we were. I mean, they were pencil and paper, they were Excel spreadsheets and telephones. They brought out an IT system very like the one we have, which was bodged together very quickly, very crude, very simple. But over the intervening months, what they've done is they've made it work. So they have now got a very slick system that ties in the airlines, ties in the laboratories, ties in the health centres, and ties in the public health people. And it just works. It's very elegant and very smooth. In the same kind of way, we have failed with our contact tracing because we have drawn the wrong conclusions from other people's experience. The British did something similar to what we're doing. They ran contact tracing predominantly out of large call centres. Now, our contact tracing has worked much better than theirs, but it has worked much less well than it should have. And we are now 13 months into a major pandemic. We are still doing contact tracing held together with telephones and quite literally with string and sealing wax. And that is not acceptable. What we've not done is what most countries that have successfully reduced case numbers have done, which is to roll out public health teams on the ground. And these are teams of maybe 4 or 5 people reporting into a public health consultant and who would be responsible for case identification, contact tracing, source identification, and supporting isolation, which speaks to some of the points Margaret has made. I've often been asked about isolation, and I have no problem isolating. My children are grown. There's a spare bedroom in the house. I can move into it. Not everyone is in that happy position. but that hasn't really been put in place properly. And Margaret said this right at the beginning, that we needed to do this, we needed to do it fast, and we need to keep on doing it. And we did it fast, but then we stopped dead. And we're still doing it now the way we were doing it 11 months ago. And the result of this is that there have been some changes, Margaret, but not on the scale required or anything close. If I look
well, for vulnerable groups, we've never done it that way. Yeah, we have done contact tracing bespoke and isolation bespoke, but it's on a shoestring. So so we've taken our vulnerable groups out of contact tracing. We take them out of CMP, put them straight into public health. And sometimes, but in the first wave, obviously, we were just floundering.
Yeah, and that seems like the right thing to do. I mean, that seems an obviously sensible thing to do. But we haven't scaled up public health to the point at which we can contact trace other people. And that's been a real challenge. So we really haven't addressed the problems. We haven't learned from what worked, what didn't work. What we should probably have done is copied what you did for everybody, not just for vulnerable groups. But you were doing the right thing. There's no doubt about that. But we're not doing the right thing for the general public. And the result is that the burden of controlling the disease has been placed entirely on the shoulders of the general public. And they get upbraided on a regular basis for not complying with restrictions. And we heard in the last few days, people of Donegal being eaten from a height by people in Neffet for nothing in particular that they themselves could control. And that is not a way to run a pandemic. We know, you will know from your own experience with Ebola that you controlled Ebola by getting the local community on side. You didn't control Ebola by sitting in the capital issuing radio messages.
But I have to say that you raised an interesting point. I went out to the airport actually as part of my brief in understanding the process whereby people enter into the asylum process and the pathway and the border controls. And I did find them myself saying, what part of non-essential travel do the airlines not get? And,
yes.
Because I was looking at big planes out on the tarmac, like from Dubai and Turkey, and I say, what? Anyway, you raised some interesting points about, I think some of them, the system does probably appreciate that whole thing about contact management and contact tracing. What can I say? Like, as somebody who works in the system, we have to be optimistic. And if we just spent all our time being critical, we'd just run ourselves into the ground, which we do anyway, very regularly.
I think, Margaret, you also made a very interesting point there where you said that the pandemic has highlighted the inequalities that already existed in our society. But I think that your work that you've described there has also shown that there are strategies that work. There are effective measures that can be taken. So your success with the homeless community in the earlier waves, for example, and providing supported isolation. So when people need to isolate, giving them somewhere to isolate, not presuming that everybody has a spare room, a bathroom to themselves and a kitchen to themselves. That's an extreme form of luxury to have privacy, ultimate privacy like that, and be able to somehow prevent transmission to your family or your close community. And some of the communities you're mentioning, of course, are very close-knit. So when you mentioned a traveller, there was one area where the traveller community was 80% of the cases. This also links in with what we've heard before with close-knit communities. Once COVID gets into the community, it spreads very, very rapidly within that community because they are very close-knit and involved in each other's lives. And so that's not surprising. And then if you're talking with people with no space to isolate, it's crazy. So the kind of things you've done have been scaled to the whole country.
I suppose looking at the travellers, for example, they're not at all interested in going to any isolation facilities. And sometimes we have worked, some of my colleagues have tried to do it and it hasn't worked out. And it's culturally, travellers are grouped in strong family networks. The family network for travellers supersedes. So the government telling us not to leave Dublin, that's meaningless for a traveller. A traveller moves between England, Ireland, north and south, county to county. So what we have done actually is try to put in extra caravans, extra portaloos, extra masks, extra sanitizer. But their travelling culture is so dependent on mixing funerals, and then they have their own tragedies. So, suicides, tragic on premature deaths, generating funerals, and the culture. And I, in Liberia during Ebola, the whole funeral ceremony was so important as well. We had to unpick that. So we've had colleagues like Ailey Kitchie in Galway giving advice on how to manage funerals, how to manage other gatherings. So there's a lot you can do. And some of it is about risk reduction and risk mitigation. And we've actually done that more than blanket, do not, because the do nots don't work. And when it comes to Roma as well, Roma are very, very difficult they are highly invisible and they don't want anybody shining a light. So we set up a special Roma hotel, we call it, and they in the inner city in Dublin. So some of these have worked very well, very labour intensive. There's special hotels also for direct provision as well as on site. And it's quite exciting what you can do. And I suppose that's what I've seen is as much as what we can do. But it's just the enormity of the scale and the complexity. And we have like 6 or 7 major groupings in 9 different community health organisations, 8 different public health departments. And in the East, we split it now into 3 because it was just unable to think. So it's a lot of complexity.
We have a question in here from Nessa Childers, who's asked about your view on the role of universal basic income. And how something like that might help in this current situation, or indeed on a permanent basis. Would, in your view, would that be something that would be helpful?
I think it is. There are anomalies in the social welfare system at the moment that, even people who come into direct provision who are allowed to work, they feel unable to leave direct provision because of the cost of rental accommodation outside. And then it's hard to find accommodation. So a universal income may work, but you also need to have a more coherent housing policy. I think the housing is the biggest, one of the biggest, most critical factors. It's not just about universal income. For many of our groups that are affected by, housing is not just bricks and mortar. There are a lot of people who are in homelessness have huge mental health addiction. Some of our younger people enter homelessness from foster care, from state care. Intellectual disability. So we need to have a much greater awareness of the data around homelessness and to not see the solution in terms of bricks and mortar. You need to hold people by their hands and support them. And I've said this all along, sometimes it's, it's like the intensive care. Public health people are sometimes providing intensive care to some of our communities. It's emergency intensive care, but you need a longer term approach.
There's a question as well about vaccination. You mentioned vaccination there towards the end when you were talking, and you said there's some vaccination programs being rolled out as we speak in Dublin city centre. What would you think about, we've talked about the vaccination priority list many times, but prioritising, for example, some of the vulnerable groups and how that would actually have a positive impact on the pandemic situation in general in the country. And I'm thinking also of groups such as migrant workers. And we know that the meat plants, for example, have suffered with major outbreaks which have spilled out into the community around them. And it tends to be migrant workers, low paid, perhaps also living then in cramped accommodation, all of these factors coming together. Would you see an argument for prioritising vaccination for some of these groups?
Oh yeah, we have a vaccine approach document, and I'm happy to share it. That was taken on board by the Chief Clinical Officer. It really identifies the key groups that require a bespoke approach and an additional HSE. We also sent a document to NIAC. NIAC looked at the morbidity and the mortality, particularly in the 6 groups, and they selected traveller, Roma and homeless, and they identified them as being at particular risk. So in fact, the HSE has embraced that. But how it's been rolled out, there are 2 streams to be rolled out, one through the general practice stream and the other through community mass vaccination clinics. And we have argued for a third way, and we're working through the third way at the moment. But we're also supporting the people like undocumented migrants, migrant workers. All our groups are entitled to access the vaccine through the mainstream. So we have worked with Translate Ireland. I think they've done it in 53 languages, and that's, I'm looking at Ivan down there. Translate Ireland has its roots in Cork, and on a relatively small budget allocated by the HSE, they've done amazing videos, because videos are much better than the written word for a lot of our people. So I haven't given you, it's a whole world. The vaccination is a new world that we're trying to grips with as well. And I agree with everything you say, but politically, the government has had a difficulty in telling people, like the other lobby groups have lobbied hard, like teachers and in Garda Síochána. So it's a nuanced way, the way we're working at the vulnerable groups. It's trying not to alienate the mainstream population.
Thanks. And I think Ivan Perry, you just mentioned him there. I think he'd like to come in here. Ivan?
Yes, Aoife, thank you. And I just wanted to thank Margaret for a really excellent presentation, which really highlights the sheer quality of the work being done on the ground by the local regional public health departments. And I suppose the issue, one of the takeout messages from this seminar is that these local regional departments need more support. They need more resources. It's a start that colleagues like Margaret are now being recognised as consultants, which should have happened decades ago. But these local departments, we now need to start in investing in them at the level where that they have the actual teams, the multidisciplinary teams that they need to actually do the sort of work that Margaret has really highlighted so effectively this afternoon.
Thank you, Ivan. And I think one clear characteristic of what Margaret's described is it's very practical solutions. So I think one thing for me as a non-public health person looking on and admiring the kind of work that's done, one thing I see is that as a group and as a discipline, it's very practical and real world. How do you deliver these solutions in a way that works for the communities that you're actually trying to help? Not, some theoretical idea of what might work, but what works in practice. And I think that's something that has really been sorely lacking over the last 13 months, that we haven't simply handed over more authority and autonomy to public health units. So the work Margaret has described is phenomenal, and it's all very practical, sensible things that ought to have been done on a much wider, a much bigger scale. And that our public health units are still under-resourced is a real shocker, actually. And there should be an ad in the newspaper and all media tomorrow, looking for 2,000 new public health staff on 6-month contracts, if that's what it needs to be. But it is absolutely imperative that these resources are provided, because it's a very practical, sensible solution that works, and we've seen that. So that's really, I think, something that's come across very clearly today. Margaret, there's another question here that is for you. It's about the humanitarian quarantine for asylum seekers that you mentioned. And the question is this already ongoing? Is this a plan? Or at what stage are you in this process?
Well, very early on, and so from the very start, one of the major outbreaks we had in the first wave, and we've had serial outbreaks in direct provision. And Balseskin in Dublin had a centre that accommodates up to 500. That's the National Reception Centre, and we had significant outbreaks there from the very start. We've had outbreaks practically in every county affecting direct provision. So one of the measures to reduce risk in the first wave was to disperse people from emergency hotels when they arrived into the country. Because people were arriving in large numbers in 2018 and 19 and the early part of 20, the Department of Justice actually accommodated them in hotels, largely in Dublin. And all around the country. And some of these hotels were not considered suitable because they were taking in other guests. And so to reduce the risk, the Department of Justice dispersed them to rural parts of the country. Unfortunately, they got caught in the crossfire of cross-transmission. And, so that was a huge, that was very challenging. But following on, we tried to identify key areas where people who arrive newly would go into a different accommodation. And we've been doing that we have been doing a form of quarantine for the past 9 months. But it has been what we designed in consultation with the Department of Justice, now children. And then mandatory quarantine came in March, and the government minister and the department were responsible for looking after those who seek asylum, which is now under Roderick O'Gorman. It's Department of Children and Youth, and there's about 5 other words, integration. They were unhappy with the word mandatory and quarantine and seeking asylum. And so for that reason, we have been working together with our partners to have a special hotel for asylum seekers and people who don't fit, on humanitarian grounds. And it's in Dublin, and numbers have gone down. So numbers entering the system, but some people are entering the system from the UK, from Northern Ireland, as well as from flights. So we have challenges with it. Some people come to the country and ask for asylum and then really disappear. They've been doing that for a long time, probably to the UK. The information systems aren't adequate at the moment, the checklist to identify those people. So, but it is humane. We have Peter McVerry Trust who provide the social, and actually the interesting thing is the social, we've always had psychosocial and medical backup for our quarantine, asylum, whether it's isolation units, whatever you call them. We've had several hotels in Dublin and in Cork, and some in Galway and Limerick, and we've had an NGO to give the psychosocial support. And that works very well. And I think that model could be also used in the mandatory hotel quarantine, because it's very hard to be locked up in a room for 14 days. And my daughter was locked up in Australia for 14 days, but she was able to share a bedroom. So we have always had the concept of exercise is very important, whether they were in isolation in City West or in isolation in bespoke facilities. And engagement with people at the door or through the phone or the intercom. We would not leave people on their own, mandatory or non-mandatory. But people can walk out.
Mm-hmm. It's extraordinary the work you're doing, Margaret, and it's interesting. You really have been involved in, it seems, just about every aspect of pandemic management in terms of what the work your group does. I just wanted to ask you a couple of questions before we wrap up, because we won't keep everybody too long. But you mentioned when you were talking, you mentioned how certain parts of the country have been unfairly highlighted, and we talked about Donegal and the criticism that's been dumped on Donegal unfairly in the last few days, and how the way the media approaches this is sometimes counterproductive. And I was just wondering, is there some advice or request that you would have for the media in particular in terms of how they could do better, that would be something more constructive in this pandemic management, and how they could act? Could they help you, for example, or would you just rather they kept their noses out?
You know, it's hard because media like good stories. They don't like lectures. They don't like mantras. They don't like generalizations. They like to know what county exactly was that funeral in that they breached. You know, they want a story, and you know, I sometimes public health people, because we dampen down the sexy stories, then we almost obliterate what's actually being done. And sometimes we might err on the side of being overly cautious in this country. Like, I suppose I've not refused an interview, but neither have I been asked. So it's not that we're afraid of the truth. At local level, I think public health people have a great opportunity, and I think that's where it should happen. You know, the media at local level can work very much with highlighting, you know, the practical things. So that'd be my approach and I've seen it. I've seen like Doug Hamilton in the Midland. You know, and I see some of it on Twitter as well. Some of it is quite effective, but it's like everything else, no one size fits all. And then you have mainstream media. It's an art in itself. It's a world, and I haven't really sought to court the media in what I've done. NGOs are better at it because they're independent.
And Margaret, then just the last thing I'd like to ask you as we wrap up here is just, what do you think, from your point of view, what's the main message that you would like people to take with them from today, from all of that extraordinary work that you have described? Is there a main message that you'd like people to take with them?
I think that social inclusion and vulnerable groups, and the whole area of marginalisation in Ireland probably is marginalised also in the way the health services are run, and that we're on the periphery, and we can no longer accept that, because a huge percentage of our population are now come under that, and it's incumbent on us to understand and know that world, and factor in all of those challenges, and not leave it to just experts in their particular areas. And the other message, vaccine is a game changer. It's fantastic. But I also pick up on your point that other things need to happen, and we're not safe until we're all safe. So no more than migration, climate change, access to medicines. These are all very important topics, global health. So it's where this fits into the bigger scheme of things, and where trade and jobs fit in. So I think an understanding of the various pressures that lead to decision making, and allowing us to make mistakes, allowing each other. And somehow I just say to myself, we'll get there in the end. We'll muddle through this. You know, I no longer think it's going to be over in a year.
Oh dear.
So, you know, in for the long haul, long haul in some way or another. But yes. I'm also very optimistic, and there's always something you can do. So that, and I hope the HSE and the system embraces flexibility and diversity in the range of things. No one size fits all. I don't know if that's a clear message.
Yeah, that's wonderful. And just as I said to you that we were wrapping up, another little question came in that you can possibly answer quickly. Just asking if you, Pauline Logan has asked if you think that the regional public health offices might be able to release weekly updates so that people would have more fine-grained local data, and that might help people understand their local situation and perhaps motivate them when they need to do more or need to do better. Is this something you think that could be possible? Is it within their gift?
Well, we have a meeting this afternoon of public health specialists, but some already no longer have a public health specialist working with social inclusion. So I bring it forward. I know that HPSC provide national data, incredibly fantastic data, but it's probably lost in translation because they have so many, other drivers of demanders for the data. But I bring that back because the old-fashioned way of having a public health department and a leader and a team was that the director of public health would work with all the stakeholders and the partners. And I suppose a lot of people have been siloed into literally fighting outbreaks. And not, we need to pay attention to prevention, communication, control, the whole outbreak response that we were trained to do. And sometimes I think, well, just let it all, wash over me and just concentrate on the important things and try to think of the important things. And sometimes that could be just communication.
Yeah. Oh, that's great, Margaret. Thank you so much for that. I'm glad we could fit that question in. So I think it's time to wrap up now. So I just want to say thank you to everybody for a really wonderful session. I think this has been really informative, shining a light on a very, very important aspect of the pandemic and the pandemic management and the correct and effective pandemic response. And so thank you to James Merrick for the situation update as usual. Thank you to Claire Kelly for that wonderful insight on the various psychological biases that affect how we react and respond. But most especially thank you to Dr. Margaret Fitzgerald. That was such an interesting insight into the work of public health doctors and specifically the social inclusion and working with vulnerable groups. I think this really highlights such an important aspect of what needs to be done in our country and in every country. One thing this pandemic has definitely highlighted the inequalities in our country and in the world. And these inequalities affect us all, even if we aren't members of those vulnerable groups that are mentioned, because the fact that the pandemic has been neglected in certain parts of our society has allowed it to be maintained for such a long time within our country, and indeed the same story is happening in other countries. So the work in engaging with vulnerable groups and with certain groups that are marginalised is really important for those groups, definitely, but it is important for us all if we were taking a slightly more selfish view and you're not a member of those groups. So I think that's something to remember. And the work that Margaret has described there, I think it's really interesting to see what public health units are capable of, the kind of work that goes on, and how it's very practical and solutions focused, engaging with people, peer engagement as well. That's really wonderful and really powerful work. And I'm just so impressed by the amount of work you've done and the type of work you're doing, Margaret. It's really wonderful. And I'm so pleased that you were able to come today to tell us about that. So thank you, Margaret. Thank you, everybody. And thank you to our audience for participating today. Bye-bye.